A patient presents in the emergency department with sudden, excruciating pains surrounding a recently contaminated wound. Within hours, the site swells with fluid, the skin turns a bruised maroon, and gas bubbles crackle under the surface. This is gas gangrene. It is one of the most rapidly fatal soft tissue infections in medicine, making it a high-stakes emergency on the wards and heavily tested on medical board exams. Beneath the skin, the causative bacteria multiply exponentially in the oxygen-deprived environment of deep muscle tissue, advancing the necrosis margin by inches per hour. These pathogens belong to the Clostridium genus. They are gram-positive, rod-shaped, spore-forming bacilli. Because they are strictly anaerobic, they thrive in necrotic tissue, yet their spores are entirely ubiquitous, lying dormant in soil and throughout the human gastrointestinal tract. A biopsy of this dying muscle tissue reveals a startling clinical paradox. Despite massive, advancing necrosis and unchecked bacterial replication, the histological slides show a near-complete absence of local inflammatory immune cells. The body appears to mount no cellular defense. Answering why this happens and conquering Clostridial board questions requires moving past rote memorization. You must be able to map specific toxins and patient portals of entry directly to their distinct clinical presentations. Building a systematic differential matrix allows you to instantly recognize the responsible strain and intercept these rapidly fatal syndromes before the patient slips into irreversible multi-organ failure. The first row of our matrix is traumatic gas gangrene, caused primarily by Clostridium perfringens. The clinical signature includes severe pain out of proportion to the initial injury, brawny edema, and bluish fluid-filled bullae. To understand the destruction, we have to look at the bacteria's major virulence factor, alpha toxin. This enzyme acts as both a phospholipase C and a sphingomyelinase. The alpha toxin shears the lipid bilayer of host cells, causing tissue necrosis. Entering the bloodstream, it forcibly activates GPIB/3A receptors on platelets. This strips their regulatory controls. They bind tightly with neutrophils, creating heterotypic aggregates that build into massive blockages within blood vessels. These physical plugs completely halt blood flow. The resulting vascular occlusion starves the surrounding tissue of oxygen, driving further ischemia, and perfectly explains the paradoxical paucity of leukocytes in the wound. The white blood cells simply cannot physically reach the infection site. The local damage quickly escalates to systemic cardiovascular collapse. C. perfringens also releases theta toxin, a cholesterol-dependent cytolysin that hyperactivates macrophages to release IL-1 beta, plunging the patient into vasodilatory warm shock. Simultaneously, the alpha toxin directly suppresses myocardial contractility, layering on cardiogenic cold shock. By proactively blockading the vascular supply routes and crashing the host's cardiac output, the bacteria ensure the speed of tissue destruction severely outpaces the immune system's capacity to respond. Because the tissue margin can advance centimeters per hour, the absolute clinical dogma for gas gangrene is clear. Emergent surgical debridement is the supreme priority. Physical source control takes precedence over every other intervention. A common clinical trap is relying purely on standard bactericidal agents like penicillin to handle the infection. While penicillin kills the vegetative cells, it cannot stop the toxins that are already manufactured and circulating. This makes adding clindamycin mandatory. As a bacteriostatic agent, clindamycin wedges itself into the bacterial 50S ribosomal subunit. This instantly shuts down all bacterial protein synthesis, physically stopping the production of both alpha and theta toxins, regardless of the bacterial load or growth phase. Diagnostic imaging or adjunctive treatments must never delay the transfer to the operating room. Hyperbaric oxygen is strictly an adjunctive measure. It remains highly controversial and is only utilized after surgical debridement and antibiotic therapy are secured. Survival dictates a simultaneous two-pronged attack. The surgeon physically excises the necrotic tissue, while clindamycin pharmacologically paralyzes the bacterial toxin factories.
The second row of our matrix covers spontaneous or non-traumatic gas gangrene. These patients present with sudden, profound confusion, followed by excruciating muscle pain, but they have no external wound, no trauma, and no obvious site of entry. The primary culprit here is Clostridium septicum. Unlike C. perfringens, C. septicum is aerotolerant, meaning it can survive and travel through fully oxygenated blood. This aerotolerance allows the bacteria to escape the mucosal lining of the gastrointestinal tract and seed directly into distant, entirely healthy muscle tissue via the hematogenous route. The presence of this specific organism carries a critical board association. Over 50% of patients with C. septicum bacteremia have an underlying colon malignancy, inflammatory bowel disease, or neutropenic enterocolitis, providing the physical breach in the gut wall. Treating the immediate myonecrosis with surgery and antibiotics is only half the battle. Any patient who survives spontaneous gas gangrene must undergo aggressive investigation to rule out a hidden gastrointestinal malignancy. This diagram maps 3 Clostridial enteric syndromes. C. perfringens type A spores from improperly cooled meat release a plasmid enterotoxin in the small intestine, causing mild afebrile diarrhea. Further down, C. perfringens type C utilizes beta toxin to drive severe ischemic necrosis, directly targeting the jejunum. Pig bell carries a 35 to 100% mortality rate if surgery is required, and is highly associated epidemiologically with massive mortality outbreaks following traditional pig feasts in Papua New Guinea. We contrast this directly with necrotizing enterocolitis, or NEC, in premature neonates. NEC is driven by C. perfringens type A, and it strictly strikes the ileum and the ileocecal valve, rather than the jejunum. The exact strain of C. perfringens, combined with the patient's anatomical portal of entry, completely dictates whether the patient experiences a mild 24-hour stomach bug or fatal bowel necrosis. Next on the matrix is Clostridium sordelli toxic shock syndrome. This is a rapidly fatal gynecological emergency, strongly associated with childbirth, surgical abortion, and medical abortions using mifepristone. C. sordelli presents a massive diagnostic trap. The patient is completely afebrile. Because there is no fever and pain may be minimal, the profound shock is frequently misdiagnosed as a pulmonary embolism or gastrointestinal bleed. The diagnosis is given away by extreme hallmark laboratory values. Patients exhibit profound leukocytosis, reaching 50,000 to 200,000 cells per microliter, paired with severe hemoconcentration, pushing the hematocrit to 75 or 80%. The final outlier is Clostridium tertium. Associated with malignancy and neutropenia, it is distinctly aerotolerant, and unlike other Clostridia, it often stains gram-negative on evaluation. It also possesses a dangerous pharmacological quirk. C. tertio is natively resistant to the standard penicillin and clindamycin combination, requiring targeted therapy with vancomycin or metronidazole. Assuming that all Clostridial infections present with fevers, gram-positive stains, and susceptibility to penicillin will lead to critical diagnostic errors and fatal delays in these highly specific patient populations. With the differential matrix populated, the logic of Clostridial infections becomes clear. The patient's exact clinical presentation perfectly predicts the underlying organism and its driving toxin. A contaminated wound with excruciating pain points to C. perfringens and alpha toxin. Sudden confusion, severe muscle pain, and no wound indicate C. septicum escaping or compromised GI tract. An afebrile patient in shock post-childbirth with a massive white count demands evaluation for C. sordelli. Across all traumatic and spontaneous cases of myonecrosis, the universal absolute remains the same. You cannot delay. You must surgically excise the dead tissue immediately. And you must add clindamycin to the regimen to shut down the ribosomal toxin factories, halting the chemical destruction that standard bactericidal agents leave behind. Mastering this matrix bridges the gap between memorizing abstract microbiology and developing the life-saving clinical intuition required to intercept these pathogens on the wards.